topics, and I will come back and do some of the other topics if people think they're interesting. But tonight, I thought that what I would do is I would talk a lot about what some of the different time windows are, because there's been a lot of change in the world of stroke and some of the time windows that have been going on. And I know particularly if you're in the state of Washington, you've seen some of the diversion things that have come through the legislation, and there's more change in the time windows that's going to be showing up over the next couple years. And so many times I think it's easy to get caught up in just doing things because it's on a list and check boxes. And I think it's more important to sort of know where this information comes from so that you can kind of understand the whys and everything that's behind where these time windows have happened and what's come from behind it. So there will be a little parts of this talk where it might get technical, and if it's getting too technical, then go ahead and just type in and let Sean know that you want me to slow it down and explain a little bit more, because the talk is intentionally short so that I can expound upon things if you need to. And if you don't need me to, then by gosh, we have an early night. But I really want to kind of get into some of this stuff so that you understand why it is that we are all together as a team doing some of the things that we're doing. Does that sound fair? I've heard no objections, so I'm going to say, okay. All right. Oh, yeah. Colfax gave a thumbs up, so cool. All right. So we're going to start off with a little bit of self-referential history here. The reason I'm going to go into this is because the story of the time windows, in a lot of ways, for me, is a very personal story. And part of this is the story of me as a stroke neurologist, because the time windows sort of mimic my journey through stroke. So if you need to go grab a cup of coffee because you're not interested in that part, this is the time to do it. Now, I might oversimplify a few things, but my goal today is to put stroke in the terms of a story. So it all sort of starts in 1995. 1995 is a pretty busy year, just generally speaking in society. That was the year we got Windows 1995, we got JavaScript, we got eBay, DVDs started coming out, we got Toy Story and Jumanji. We as humans did some pretty awful things to each other with, bombings and nerve gas. But for me, one of the bright and shining things that happened was the publication of the original NINDS trial that brought intravenous TPA into the world of stroke. Now, that's the year that I was in medical school. And I remember there were a few neurologists who were starting to walk around with this faraway look of wonder on their faces because of this new thing called TPA. Now, not all of them, but you could see who the dreamers were, because before that, stroke was a one and done sort of creature. You had the stroke, it was over, sorry, I'll see you in the morning. But now, in 1995, it was a beautiful time to be alive because this dream was starting. So now I'm going to give you sort of a whirlwind guided tour to not only the latest and greatest, but how we got here. Okay. Before I get into that, I need to give you some vocabulary terms that we will reference not only here in this lecture, but you're going to hear them come up anytime someone talks about stroke in the future. You might have heard these in the past and kind of gone, I wonder what those things are. Now you'll know. So the first thing, if you've ever heard of the modified Rankin scale, this is a simple 0 to 6 outcome score. It's used all the time in stroke research. I call it simple because 0 means you've recovered and you've got no symptoms at all, and 6 means you're dead. All right, pretty simple. It's used pretty often in stroke research, and it's often compared horizontally in this fashion, typically with 3-month outcomes. So they usually set it out with whatever the intervention is. Here, in this example, this would be like TPA compared to placebo. And they lay it out with the different outcome ranks of the intervention compared to the non-intervention. Now we've got a couple of different things that we talk about here when we're talking about modified Rankin. It's not just 0 to 6 where death is the bad thing and no symptoms is the good thing. People often break this down. And in a lot of studies, we say a good neurologic outcome is 0 to 2. Maybe even 0 to 1 if you're being really persnickety, but usually it's like 0 to 2 is considered a good neurologic outcome. And 5 to 6 is a bad neurologic outcome. Now 5 means you're bedbound for life. So some people would actually think that 5 is worse than death. You know, you're 100% dependent on everyone for all of your cares, bedbound, you can't do anything. Okay. The division between 3 and 4 is a pretty easy division. 3, you can walk, you might need some assistance, but you're still walking, and 4, you have to walk completely with assistance, like with a walker or something like that. So the ability to walk is the 3 to 4 breakdown. So we like the modified Rankin because you can do it over the telephone. Right? It's easy to follow up. So you'll see this in a lot of stroke research. If you've ever brought a stroke patient in, the stroke doctors are using the NIH stroke scale score. This is not a great score. This was originally a research tool that was designed for that 1995 trial. It's a 0 to almost 40-point scale, where 0 means you don't have obvious measurable stroke symptoms. It's not exactly true, but it's kind of how we rate it. And 1 to 4 is a minor stroke, and once you're over 20, it's a really bad stroke. All right, we do this very quickly to assess stroke severity, and even though it was a research tool, most of us use this to quickly assess somebody's risk for TPA. And if any of you have ever delivered a patient to me at my hospital, you'll see that I am quickly doing this NIH stroke scale score a lot of times while you are rolling the patient in the gurney down the hall to the CT scanner, and I'm doing it while we're walking down the hall with the patient, and I can get this done in under 5 minutes just to kind of get me a quick assessment score. Okay, so you know the MRS, the modified Rankin score, and you know the NIH stroke scale score. And there's one other thing that I want you to know, and that's hemorrhagic transformation, which is the risk of somebody somebody bleeding after TPA, or the risk of somebody bleeding even without TPA into a stroke. The reason I bring this one up is because not all bleeding into a stroke is the same. Everyone gets very upset when you get a follow-up CAT scan and it says that there's blood in the stroke or that there's hemorrhagic transformation. But we have a way of rating the different types, and there's 4 types. So there's only one of these types that's actually associated with bad neurologic outcomes. And I'll quickly walk you through. You probably don't need to know all of these types, but I think it's interesting, so I'll show you some of the different types. When I, as a stroke neurologist, am looking at a CAT scan and I've heard, oh my gosh, there's blood after the stroke, there's been post-stroke bleeding, I want to know what kind. So there's different kinds here. We can call it parenchymal hemorrhage type 1 or type 2. The parenchymal hemorrhage type 1 means that there's a little bit of mass effect here, or a big amount of mass effect here, or there's a little bit of hemorrhagic infarction. On this one here, you can barely see it. It's a little bit of what we call petechial hemorrhage here on this CAT scan, and it's a bit bigger here on the hemorrhagic infarction type 2. A little bit more. That's these fluffy white spots. But there's 4 different kinds, and of these 4, only one, this one here, the PH2, where you've got a lot of bleeding that's got mass effect, and it's actually pushing on the ventricles here. It's smushing this one over so that it's not symmetric. This one's nice and kind of, it's got its normal shape, and this one's been smooshed. That's an official term, smooshed. This one's been smooshed over. This is the only one that's associated with poor outcomes. So anytime a study says, oh, 12% of the patients had hemorrhagic transformation after this intervention, I don't care about that. I care about what percentage of the patients had this kind. Okay, so that's all the background that I want you to know about before we start talking about stroke time windows. So let's start off at the beginning. So if you want to know where we're going, you got to know where we've been. So we started trying to thrombolize strokes way, way back before 1960. But this was a problem because we didn't have CAT scanners until the 1970s. So people were putting thrombolytics into patients where we didn't know if there was a head bleed or a stroke or what. So those early attempts, they didn't go so well. Okay. TPA was actually discovered back in 1979. So they weren't doing thrombolysis with TPA back in 1958. They were using all sorts of other thrombolytics like urokinase and streptokinase, other things like that. So TPA was discovered 1979, but they didn't get the recombinant form until 1983. But this whole concept of really working with a clot, that's an interesting concept. And we owe a debt, amazing debt, to Spokane, Washington. Now, I don't know if you guys know this history, but this is some amazing history. Right? Prior to this landmark paper that was put out in October 1980, now I'm oversimplifying this here. Nobody really knew that clots were a bad thing. Right? In those days, MIs were not thought to be due to clots. Right? They were thought to actually be caused by inflammation followed by necrosis. And the thought that when they found thrombi in the coronaries, those were thought to be an innocent bystander, an incidental byproduct of the inflammation. And believe it or not, it was actually cardiologists in Spokane, Washington, who flew in the face of widespread professional opinion and published this paper in 1980. They were doing work with this before the 1980s, and they were actually starting to go in and trying to thrombolyse those clots in the coronaries, and they were blacklisted from conferences. They were called murderers. One of our intensivists who still works at Deaconess, Dr. Dan Colston, was a fellow at the time, and he was literally called a murderer by other physicians for thrombolysing the clots in coronaries at that time, because that wasn't the problem. It was kind of amazing. So it wasn't until this article in 1980 came out that the world started realizing that clots were actually the culprit in MI. And that changed the world. So it was massive amounts of controversy worldwide. But if it weren't for Dr. DeWood, Bob Notsky, and their whole team, we would not today have STEMI protocols, thrombolysis, thrombectomies, both in cardiology and the world of stroke, and everything that followed. Without the concept that they put forward, we in the world of stroke would not have moved in the direction of thrombolysis. So you have to know where you came from before you can move ahead. So when I have taught the residents and the medical students and say that the cardiologists in Spokane have saved millions of lives worldwide, I'm not actually exaggerating. So a little cocktail party history for you to wow people with. So we moved on, thanks to all of that, to the world of IV-TPA. And IV-TPA has been our only reliable pharmacologic therapy of benefit since those days in 1995. Still, we've got a 4.5-hour time window that is clearly defined. And it has got multiple constraints because you've got this risk of hemorrhage, both in the brain and systemically. You can get early reperfusion, but gosh, it doesn't work well in large vessel occlusions. The thing about IV-TPA is it works really well on small clots. It works best on thrombi that are 5 millimeters or less in size. The problem when we're talking large vessel occlusions, and the one that I really like to point out, is if you've got a carotid occlusion here at the bifurcation in your neck at the common and internal carotid, let's say you occlude right there at the base of your internal carotid artery. Your internal carotid has no branches until it gets up here to the back of the eye. So if you occlude it right here, you've got a stagnant standing column of blood. And very rapidly, that will become a progressive thrombus that can be up to 15 centimeters in length. So TPA is not going to work on 15 centimeters. All right? So it's good on the smaller clots, but not on these. So it's useful, but it's only getting some of the strokes. So where does that leave us? Well, it means we're still looking for other pharmacologic alternatives, and there's research on trying to use tenecteplase, particularly in some of the critical access hospitals that can't stock alteplase because of expense. I know a lot of you have had the experience of not knowing that last known well time. You know, finding a patient, no one knows when they were seen last. You know, they've been found down and maybe family talked to them a week ago. So that last known well time is tough sometimes. And when we look at the numbers, at least when we looked at them several years ago, we're seeing that maybe not quite 7% of the patients in the United States are actually getting IV-TPA. And one of the things it gets us is this last known well time. Well, we know that time is a key thing. And in fact, a few years ago, Dr. Jeff Saver at UCLA actually calculated it out. And for a large vessel occlusion, we actually figured out that you're losing 32,000 brain cells. That's not just neurons, that's neurons and glia per second in an untreated large vessel occlusion. Per minute, almost 2 million. Per hour, 120 million. And per stroke, a little over 1 billion brain cells if you can't open that blood vessel back up. And we've got the equivalent of how many years that brain ages with this kind of cell loss. So I don't know about you, but I'm at the age right now where I want every single cell that I can preserve, because I'm very vain about my age, and I'm vain about my brain age too. So I want every single cell I can keep going. I don't want to be losing anything per second. And I really don't want to be taking years off my brain age. I don't want to be taking any years off this age either. So time is brain. And we've had this concept, you've heard it at, hundreds and hundreds of lectures and community education programs. We know this part. But here's our problem. We've got these excluded patients because that time of onset is not known in up to 27% of the patients. Well, when we look at it, it's not only that time of onset isn't known, we've got this thing called the wake-up stroke. And I know you've seen a bunch of those too. Up to 14% of strokes presenting to the emergency departments are wake-up strokes, almost 60,000 of them in the United States. And many of those would meet all other eligible criteria if we just had some sort of time and they weren't a wake-up stroke. Up to 36% of them could be treated. So this is a lost population, the wake-up stroke patient. What are we going to do for those folks? That's kind of a low-hanging fruit for us. So I want you to put the wake-up stroke patients in your back pocket, because that's something that we've been working on really intensely in the stroke world, and I'm going to come back to that by the end of this lecture. So small vessel strokes, we've had a pretty good handle on those. And small thrombi, the ones that are less than 5 millimeters, we kind of have a decent idea how to work with that. And people with a good time last known well, we've got a plan for them. We know how to do that. But it's those large vessel strokes, the ones that aren't going to be dissolved with TPA. We had this great idea. We would do what the cardiologists do, and we would go in and we'd take a catheter and we'd pull them out, the thrombectomies. But our problem with this is that none of those trials ever worked. It made sense. Open the blood vessel, reperfuse the brain, solve the problem. What is there that doesn't work in that? And yet, before 2015, all of those trials kept coming up negative, to the point that the FDA said, cut it out. We're not going to reimburse for these anymore. And I had my interventionalist pretty much sitting on street corners holding up cardboard signs saying, we'll reperfuse for food. Because no one was going to give them anything, any reimbursement for doing this. We had these great catheters. There was one that we started off with many years ago called the Mercy Retriever, and it looked like a little wine corkscrew. And it would get the clot and it would open things up, but we weren't seeing great study results. And those modified RANKIN scores that we were looking at, we weren't seeing improvement with those. So they redesigned it, and they put little threads on the end to catch the clots more, the Mercy 2. Again, we weren't seeing improvement. So these trials, they weren't doing anything, but the interventionalists were getting really good at them. It all made great sense, but we just kept hitting a wall. And so finally the FDA said, cut it out. We're just not going to support doing this anymore. We were giving up. I was trying to treat these kinds of strokes medically, and those strokes don't get better medically. It was almost a death sentence. They were all coming up modified RANKINs of 5 and 6. But in the meantime, the companies were developing new devices, no longer looking like corkscrews, but something called stent retrievers. They actually looked like the cardiac stents, but they were removable. You'd put them in, the stent would grab the clot, and then you'd pull them out. So they called them the stent retrievers. There was a landslide of positive trials that came out in 2015. Now, I was at the International Stroke Conference when they reported 4 studies back to back that were all positive. I got to tell you, Neurologists, we're not exciting people. This may come as a surprise to you, but we're kind of nerdy. So to be at the International Stroke Conference with a bunch of neurologists, when these 4 trials were reported, and they were all stunningly positive, amazingly positive, one right after another, there was pretty much rioting in the aisles. I mean, literally, neurologists were jumping up and down. And if you've ever seen excited neurologists in mass, it's a sight you just won't believe. So this is what the stent retrievers look like. There's 2 main ones that are being used, Solitaire and Trevo. So you inflate a balloon, and you take your guide wire up into the vessel. Here's this clot right here. You take your guide wire through the clot and your sheath through the clot, and once it's there, you pull the sheath back and you extend this stent. You deploy the stent. It looks like chicken wire mesh, okay? This balloon is inflated so that the interventionalist can actually provide back suction as they pull everything back out. And with the back suction, then none of these pieces are likely to break off and advance up into other blood vessels. When this first came out, I was worried that as they did back suction that they might be causing strokes by sucking the blood away from other parts of the brain, but it turns out that doesn't happen. So once they've engaged the clot here and they're providing the back suction, they retract this entire device here, the retriever, and now the clot is engaged with all of this mesh, and they're able to pull it all the way back out. And then they deflate the balloon. Those things worked amazingly. Many times they can get the clot out just on the first pass. So the first trial that came out was called Mr. Clean. And it was the first one. It was wildly positive. And people were incredibly excited. There was only one problem with Mr. Clean, is after it came out and was published, all of the other trials had to stop. They all had to close early, because there's this thing in research where you can't ethically keep going on with the other trials if you've got strong proof that one treatment is better than the other. Because you can't randomize people to placebo if you've got strong evidence that the treatment is much better. So once Mr. Clean came out, all these other great trials that were also going on had to shut down. So we didn't get the best data that we wanted from all the other trials, but they were still pretty good, even though they were what we call underpowered. All of these trials still had something we call a number needed to treat between 4 people and 7 people to get one person with a good neurologic outcome. And by that, most of the trials meant a modified Rankin score between 0 and 2. There's almost nothing in medicine that has a number needed to treat between 4 and 7. Most treatments have numbers needed to treat, you know, if you're lucky, between 10 and 20. You treat between 10 and 20 people to get one good outcome. So a number needed to treat of 4 is amazing. Just amazing. It's one of the reasons why we were like all jumping up and down and partying at the conference. But for me, what was amazing looking back at this is this was the first time we started to use imaging to select our patients to give us longer time windows. So everything before this, we just had TPA and we had a strict time window of 3 hours or 4.5 hours. Didn't matter. That was the time. It was a clock time and it was exact. But suddenly, with these large vessel occlusions, we were now using imaging to extend the time window, which had never happened before. So we had to prove that these patients had a large vessel occlusion in order for them to have the treatment. I mean, that makes sense. And one of the trials, ESCAPE, required that you had to show that there were good collateral vessels, good detour paths. Now, all of this was in the anterior part of the brain in the carotid territory. So far, nobody's mucked around in the back of the brain, even to this day. And none of these required what we call perfusion studies. So it was real basic imaging stuff. But it was enough that we changed the Washington Department of Health stroke triage tool. We rewrote our statewide EMS triage tool for strokes based on those thrombectomy trials to divert patients suspected of having a large vessel occlusion to hospitals that could do mechanical thrombectomy. And that's been the law of the land, all right? So it made a big difference. But we can get better. After that, there was the development of something called rapid software. And this is where we get to the thrombectomy trials round 2. Okay. Using the rapid software is something that if you've ever come and you've dropped off a patient to me, we're looking at perfusion. So here, I'm not looking at the blood vessels. The perfusion study with rapid gives me a quick assessment of the blood flow through the vessels. So I like this because this is real simple, and I'm kind of a simple person at heart. What I've got here on the left side, and this is what I'm using in the middle of my code stroke. So I'm using this in that emergency situation. I can get this stuff real fast, okay? This is part of my code stroke CT scan. And I run the contrast dye through the patient real quick. It's giving me the CT angiogram, and then this is the perfusion study that generates, usually while I'm getting the patient off the table. So this side over here shows me the area where cerebral blood flow is low. It's less than 30% of normal. This is what we're calling the core of the stroke in, well, red. Not quite red, but I'm thinking of it as red. So red means stop, right? This is the core of the stroke. Over here is all the area where the blood flow is sluggish. This is the penumbra. This is all of the area that is at risk. So I am comparing the core of the stroke to the penumbra. And that's the volume that is threatened. And I put together a ratio here, the mismatch ratio. And most of the studies look at a mismatch ratio greater than 1.5 as a patient who's got a large vessel occlusion who would benefit from a mechanical thrombectomy. So I can get this study and whip it together and have a good sense of which patients might benefit from a blood flow standpoint of getting that intervention. So I'm using this software because what I want to do now, rather than just looking at a prolonged time window in the setting of large vessel occlusion that again is a finite prolonged time window, now I want to do something fancier. Now, I want to risk stratify patients based on the amount of tissue that's already dead and the amount that's already at risk. Because that first round of things, that let me push the time window out to 6 hours. So we've gone from 3 hours with IV TPA to 4.5 hours with IV TPA to 6 hours with mechanical thrombectomy. But I want to go further. So if I use that rapid stuff, then what I can do is I can look at people who might have a chance of having something salvageable much longer. If I look with that perfusion, I can see who's got territory that I can still save hours out, because now I'm doing something different. I'm looking at it as on a person by person basis, based on their blood flow. What I'm doing here is something I dreamed about doing as a medical student, which is getting rid of the concept of a clock. When I started as a neurologist, everyone stared at the clock on the wall and said, we've got 3 hours. We got 4 hours. We got 6 hours. But what if I've got 6 hours, but my friend who's at Deer Park with the same stroke, he's got 7 hours because his brain is different than mine? What if Sean in the back has a brain that's different than mine, and we both had our stroke at the same time, but Sean's brain gives him 8 hours before it's too late? Because we're all different human beings. So the clock on the wall doesn't mean as much. And the only way we can tell that is by looking at blood flow. This is what I dreamed about way back when, is trying to figure out how to tell who's different. And that's what they started doing with these 2 trials. This is going to get a little bit more complicated. So Sean, if you're back there and people have questions about these 2 trials, please let me know.
I did have a request, Madeline, from one of the kids. When you're referring to a picture, if you don't mind using your pointer to just point at which picture you're referring to. I think they were just trying to track when you were talking. So right now, I think you're good. I think it's just when you have pictures and things like that.
Okay. Okay. Sorry, I thought I was using the mouse. I will be better at mousing.
Yeah. The only thing is that the screen is what they're seeing. So you have to take that mouse and put it over on the screen off to your side, because that's what they're actually seeing. They're not seeing the computer you're staring at.
Oh, okay. Mea culpa. All right. Do I have one of those? Ah, yes. Okay, here we go.
So they're like this.
Like this?
So if you take this thing and go over here,
yes.
they can see that, but they can't see this.
Got it. Okay. Thank you for letting me know about that. Okay. I hope that's better. Okay. So, these are the 2 trials that we are using right now to help us figure out who gets thrombectomies. Okay? So these are the 2 trials that are helping us make the big decisions. And I'm treating some people out to 16 or 24 hours now. We may start treating people out potentially longer. And it's based on the work done in these 2 trials. I will try and explain it in detail. So if you don't understand anything, let Sean know, okay? So the Dawn trial and the other one that came out, they came out within a couple of months of each other. And these just came out last year. So this is relatively fresh stuff. You'll notice that the researchers go through a lot of work to try and get these names. So Dawn is from diffusion weighted imaging or CT perfusion assessment with clinical mismatch in the triage of wake up and late presenting strokes undergoing neurointervention with Trevo. And that's where they got the DAWN. It was a stretch, okay? So what they did is they took 26 different hospitals who were all doing these thrombectomies a lot. So these were experienced docs, okay? They only had 206 patients, but in our world, that's a lot of thrombectomies. So they did 107 thrombectomies compared to 99 controls. And here, they went all the way out to 24 hours with these patients. But they had to have a significant mismatch. And they were mostly using this rapid software. So they had to have a big difference between the core of the stroke and the penumbra. They had to have a significant ratio difference. Okay? With me so far? I'm hoping that's a yes. All right. Now, they did have 3 different groups, and you don't have to really know all the details of the groups, except that they were really, really detail-oriented, so that if you were an old person here, your stroke had to be smaller, you know, and if you were young, you could have a big stroke or a small stroke, but there had to be a significant disproportionate deficit. Right? You had to have a lot of difference in your strokes. You had to have a big penumbra, is what they were saying. Okay? So they were doing a really good job on this one. And they stopped this trial early, because on one of the safety assessments in this trial, along the way, it became obvious real soon that even though they were going much further out in time than the standard 6 hours that we've been doing for a long time now, since those initial 2015 studies, even though they were going out in the 24-hour range, thrombectomy was much better than standard care. And when I'm talking about much better, when we're comparing functional independence here, and that's usually a modified Rankin in the 0 to 2 range, it was almost 50% in thrombectomies compared to just standard stroke care. Right? The bleeding rate, the intracerebral hemorrhage rate, 3% for standard care, 6% for the intracranial hemorrhage. And the death rate, about the same, no statistical difference. 60% of these patients were the wake-up stroke category. This was a huge win. So, looking at this trial, and here's where it becomes important for you guys. If we try and look at retrospective studies and think about who shows up in the ER, we can estimate that maybe 1/3 of the patients who show up to an emergency department with large vessel occlusions in a carotid territory vessel within that 6 to 24-hour time window that matches this study. 1/3 of the patients who show up with this criteria would meet the enrollment criteria of this trial. Right? Now, 60% of these patients here were wake-up strokes. And that places them at the unknown time of onset, which is the traditional exclusion criteria for IV thrombolysis. Unknown time of onset usually means we don't do anything for them. And yet here, those patients are having this 49% functional independence. This trial, again, was another one that took the neuro world by storm. Around the same time as DAWN came out, the DEFUSE 3 trial came out. DAWN used NIH stroke scale scores as one of the key enrollment features. NIH stroke scale is a clinical scale. Okay, so it was using clinical scales and perfusion. DEFUSE 3 doesn't care about the clinical scores. DEFUSE 3 is all about the imaging. Okay. So the DEFUSE 3 trial approached this same problem, but from a slightly different angle. Again, they did the same sort of thing. They had 38 different hospitals 182 patients, randomized, about half of them to thrombectomies, about half of them controls. They did not go out to 24 hours. They went out to 16 hours. You had to have an imaging proven mismatch. So using that rapid software, they said, okay, you have to have a big ratio. It's got to be like 1.8 or more. The stroke core cannot be that big. It's got to be less than 70 cc's, and you've got to show a significant mismatch volume. It's got to be at least 15 mils of penumbra or more. Right? You got to really show it on the imaging that there's something worth going after. But we don't care what the clinical looks like. You just got to show us that the pictures are good. And again, here's that modified RANKIN that I was telling you about that we use in our stroke trials all the time, with the medical intervention on the bottom and endovascular, the mechanical thrombectomy on the top. Okay? Where 0, 1, and 2 are considered a good outcome, and 5 and 6 are the things we want to avoid. So looking at treatment just with standard medical care on its own, 0, 1, and 2, that group is expanded up here to this, and the poor outcomes here have constricted to this. So there's a significant difference. By significant, I mean the odds ratio is 2.77, and it's statistically significant with a p-value of less than 0.001. There's a significant difference here that favors the mechanical thrombectomy over the medical therapy group. And if you're looking at the patients who are in that good outcome, the modified RANKIN of 0 to 2 here, you get 45% of the patients in that functionally independent group here, up here in the mechanical thrombectomy, compared to 17% here in medical therapy. So again, pretty significant, amazing results. So these two trials gave us, they weren't identical criteria, but they were pretty overlapping criteria. And both of them focused on using this new type of imaging, imaging the penumbra, to help select individual patients for very prolonged treatment times. So that concept now of a specific one-size-fits-all time window doesn't work anymore. All right? And that's something that I've been waiting for a really long time. As we got rid of the concept of a time clock and started going to a tissue clock. But wait, there's more. Because taking that information and that new paradigm shift, we can now go back to IV TPA and look at good old-fashioned IV TPA through new eyes. And that's where the Wake Up trial came from. Because that whole group we talked about way back at the beginning, that group that we couldn't treat because we didn't know their time of onset, the people who wake up with their strokes, right? They did that same sort of thing, a randomized controlled trial. This time it was big. 8 different countries across the world were involved, 70 different hospitals. They were trying to get 800 patients, but they lost funding, so they could only get 500 patients. You know, realities of research. And they enrolled patients who were outside of the 4.5-hour time window and who weren't planning to have mechanical thrombectomy. And they used imaging on a case-by-case basis to look at whether or not they could potentially receive TPA. So instead of using that rapid software they used something a little bit different. They used MRI, and they looked at the core of a stroke on the MRI, less than a third of the territory, and they used flare signal, which on MRI means that the stroke isn't that old. So it was a different way of looking at it. It was an interesting choice, but you know, they went ahead and they looked at that. And they said, okay, well, what can we do with this wake-up trial? And most of these folks had medium severity strokes. The NIH was 6, and about half of them got TPA, and we figure they were maybe 10 hours last known well, both the TPA and the placebo strokes, and about 90% of them turned out to be stroke on awakening. Now, what's interesting about this is the size of the stroke itself wasn't any different between the two groups when they were done. So it didn't make a difference, treatment or non-treatment, in the actual size of the stroke. But their quality of life scales were different, which is intriguing. With the same size stroke, the people who got the TPA, their 0s, 1s, and 2s, they had better functional outcomes than the people who got placebo, even with the same size stroke, which was interesting. And the hemorrhages, and remember I said that I really mostly cared about this specific type of hemorrhage, the PH2s, that was about 2% in the TPA group, which is kind of what we saw in the original TPA trial back in 1995, even though this is 10 hours out. And it was, you know, about less than 0.5% in the placebo group. So we didn't see excessive hemorrhage. We did see a higher likelihood of an outcome that was no or minimal neurologic deficit at 3 months compared to placebo. It didn't quite meet statistical significance here with this p-value. The p-value we would have wanted would be less than 0.001, but it was pretty close. So everyone was very intrigued by this, and we said, okay, look at that. We used imaging criteria here to guide our patient selection in this prolonged time window for IV TPA, using IV TPA way past the 4.5-hour time window, getting better functional outcomes, and yeah, some more hemorrhages, but looks like better functional outcomes. So we did have a few problems with this trial, and the main problems you understand are because the trial stopped early and we had 300 fewer patients than it was supposed to have. And from a safety standpoint, that we don't know if we had the 300 extra patients, would that difference in hemorrhage have actually expanded to be worse? We also saw that patients who had strokes that were more severe than the NIH of 6, we weren't seeing much of evidence of benefit there. So we just don't know what would have happened if that trial had gone to full. But it was really interesting that they got away with giving IV TPA 10 hours out for a lot of people and did not see massive amounts of death or massive amounts of hemorrhage, and actually saw improvement in a lot of them. So many of us went, huh, well, you look at that. It may be that if we're careful about how to select folks, we may still be able to do IV TPA in some people. Now, this is key because think of the small hospitals and the people who you can't transport to a larger hospital in time for some other treatment, or people that you wouldn't be doing mechanical thrombectomy on. So there's a whole patient population that this might be helpful for. We're not ready for it yet. It's not ready for prime time, but then there was this trial, also in that same sort of vein. The EXTEND trial went out to 9 hours. So again, people outside of that 4.5-hour time window, and they looked at wake-up strokes. You didn't need a large vessel occlusion. You could use either CT perfusion or MR perfusion. And for this one, they didn't need a big mismatch ratio, 1.2 or more. Absolute difference in volume, 10 mils, or core infarct volume, less than 70. And they had planned to enroll 310 patients. But do you remember that problem with Mr. Clean, where when it started showing good results, then all the other trials had to stop? This trial stopped early because the wake-up trial was showing some decent-looking results. So they had to stop at 225 patients. So it's sort of this cascading effect. So they didn't get to enroll everyone they wanted to enroll. So they had 113 patients, TPA, 112 in placebo, but they got 65 wake-up patients, and 25% were in this 6 to 9 hour group. So these are people that some of them might have been able to get mechanical thrombectomy, but they didn't. Instead, they got IV TPA. Some of them wouldn't have qualified for mechanical thrombectomy. It was kind of a mixed bag, but all of these folks got IV TPA in a prolonged time window. And again, when you compare them, here, the 0 to 2 hour, the 0 to 2 modified Rankin compared to the 0 to 2 up here on alteplase expands, and the 5 to 6 decreases. Now, EXTEND was a little bit weird. They actually, they really wanted to be specific, so they used a 0 to 1, because they really wanted excellent outcomes. The problem with doing that is then they ended up not meeting statistical significance. They had this P of 0.04, and once they've defined that this is what they're shooting for, they can't go back later on and undefine it. So they did actually do relatively well with this one here, with going to the 0 to 2, but not in the 0 to 1 range. So it was interesting. It was really fascinating. They did pretty well with their patients, and they did have a bit more hemorrhages than we would have thought, 6% hemorrhages compared to 1%. They had some problems with this one. Their door to needle time was 2 hours, which is way beyond anything that we do. I mean, our door to needle time is supposed to be 45 minutes or less. Some of us are trying to do 30 minutes or less. And I did have some ethical problems with this, is because a lot of those patients had large vessel occlusions and would have benefited from mechanical thrombectomy, and they didn't do mechanical on these folks, and ethically I've got a problem with that. So I did have a problem with some of the conclusions they drew in this trial. Neither the EXTEND nor the Wake-Up trial shows that we're ready for prime time with prolonged intravenous TPA. But both of them show there's some solid trends. And I figure within the next few years, you're going to be seeing us do prolonged IV TPA, especially I think in the rural hospitals. The critical access hospitals, I bet you'll be seeing that. The key thing here is that time window is breaking all the time. So we have clearly left behind the concept of a ticking clock, of the clock on the wall, and gone to a tissue clock. So over the time that I've been practicing, from 1995, when I said that this was a personal journey, what I've watched is in the beginning, stroke was a static one-time event. And then stroke turned into an evolving event, but it still had a finite time to intervene that was the same for all humans. And we had time is brain and the era of the time clock. And then we switched to, okay, strokes evolve and they're finite, but hey, large vessel occlusions have a longer finite time than others. But then we got that strokes are finite, except large vessel occlusions can have a variable time based on their collateral flow. And now perhaps all strokes have variable times to intervene based on perfusion. So where are we now? The era of the time clock is drawing to an end, and the era of the tissue clock, you're in the middle of it. So we used to say time is brain, but maybe what we should be saying now is flow and time are brain. I've been waiting for this for a long time. And so you guys, I am really looking forward to working with you all in the next decade. Any questions?
I haven't had anything come to the chat window except for the party going on in Ferry County. But besides that, I don't know if y'all can see webcams, but they're like dancing and stuff in Ferry County.
Dang, I am at the wrong place.
Yeah, they're out of control.
Man, you farriers.
We've got to do something about taking away their fun and their enjoyment. But anybody have any questions for Madeline before she goes over the answers to the post test for this evening? Madeline, do you have a copy of the post test, or you want me to read the questions?
Oh, I want to hear you do like dramatic readings. And then I think you got a call on Ferry to do we'll at least one of the answers.
Yeah, we'll see if they come up with the right answer. They didn't even listen through most of your presentation. They were too busy talking about disco balls and dancing poles.
Dang, you guys.
Yeah,
you guys suck, man.
See the chat box going on over here. It's out of control right now. They had dollar bills, and it was ugly. Ugly, let me tell you. Yeah, see, Madeline knows what I'm talking about. Make it rain. I love it. So here is our first question.
Oh, wait, do they get prizes? Nania used to give free hats.
I do have a hat sitting around in somewhere. Oh,
I think the hat should go to whoever got the bonus question right.
Yeah, Curlew asked, what is the harm in giving TPA when LKW is unknown?
Right now, the harm in giving it when last known well is unknown is your undetermined risk of hemorrhage. And that's what we're still trying to figure out with those last two trials that I was talking about with Wake Up and with Extend. So particularly when we were looking at Extend, and also a little bit with Wake Up, is we don't have a solid grasp yet on which patients have acceptable hemorrhage rates and which ones don't, and what criteria should we be using to figure out who is safe and who isn't. So most of these folks, we kind of have good guesswork. You know, you figure if you're not seeing significant signs of infarct that's already evolved on the CAT scan, and you're seeing a large penumbra on the perfusion, those are what we think are reasonable options, that those are low-hanging fruit for people that you might be able to give IV TPA to. But the evidence-based medicine so far hasn't proven yet to everyone's full satisfaction that that's the way to go. Now, there are some places that have jumped ahead and are starting to do it even without the research trial backup yet. And I am positive that in a couple of years, we'll have that research showing us how to pick the folks with no clear-cut last known well who can receive the TPA safely. But it's kind of like giving the TPA like this right now. So if you do it and you screw up and the person dies, you're in a bad way. You know, you don't really have a good leg to stand on. So we'll know in a couple of years who we can do that with, who can get the TPA without a good last known well. We just don't have the criteria fully hammered out and who's safe and who ain't.
Cool, perfect. Any other questions for Madeline before we go over these multiple choice or these post-test questions? If so, feel free to throw it in the chat window. But for now, we'll go through these 5 questions. First question is, the modified Rankin score is a 6-point outcome score used in research where? Is it A, B, C, D, or E? Steptoe Fire says E. Is that correct? All of the above, Madeline? This was.
I would say yes.
Yeah,
I would say yes.
Sorry,
I'd say yes.
I forgot this is not sitting in front of you. A was 0 to 2 is considered a good neurological outcome. B was 5 to 6 is considered a poor neurologic outcome. C was the difference between 3 and 4 is the difference between walking with or without assistance. D is 5 is sometimes considered worse than deaf by some people. And then E was all of the above.
E is the correct answer. Thank you, Steptoe.
Perfect. Nice job. Question number 2, true or false? Thrombi clots were always known to be a primary etiology of damage in heart attacks and strokes. Steptoe was first on the false answer. They get 2
False.
for 2.
False is correct.
Perfect. Keaton also got false. I only calling him out because he's tuning in from Yellowstone, Montana, I believe, and said that they got like over a foot of snow, so that he's like snowed in. He said the nearest place to go get training is a 3-hour snowmobile ride away, so he's very secluded. So.
Oh man, yeah. Sometimes I work out there at Ermac. Hi there, at Yellowstone, Montana.
Yeah, Keaton, is that where you're currently at? You can just type it in the chat box. But question number 3, if untreated large vessel strokes, how many brains, neurons, and glial cells are lost per minute?
Glial cells.
Glial. Wyoming, by the way, is what it looks like he says. 32,000, 1.9 million, 120 million, less than 12 parsecs, or 1.2 billion, and I think he's saying the answer is 120 million. Is that right? Nope. Reclamation said, oh, he was saying B, sorry. But Reclamation Fire said B as well, 1.9 million.
Bing, 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 bing.
Nice job. Sorry, Keaton, I misspoke for you, pal. Question number 4, potential for IV TPA to be given out to 9 hours was seen in the, everyone is saying the DAWN trial.
That's IV TPA. Reconsider
yeah,
yourselves, folks.
Looks like
IV
a bunch of people
TPA.
are saying C, so extend trial.
Reconsider yourselves, folks.
Extend trial?
Yes, you're thinking the appropriate stuff.
Okay.
There's one other. Oh, yep, the extend trial. Thank you.
Okay. And then question 5, true or false, of the 4 types of hemorrhagic transformation of ischemic stroke, 3 of the 4 types are worse than outcome. Clearly says false.
I'm losing you there.
Can you hear me now?
Yep.
So false, of the 4 types of hemorrhagic transformation of ischemic stroke, 3 of the 4 types are associated with worsening.
For a bonus, what's the one I do worry about?
Reclamation says pH1.
Reclamation is so close.
Ferry County, Parlax second, pH2.
Perfect.
Nice. Look at you guys. That was pH2 Ferry County said Parlac second, and Plentywood just said PH2. So both of them jumped in there. Ferry County was listening during their dance party. I like it.
Very nice. Very nice.
Now they're doing the wave again. Good God. And the bonus question. Parsec is abbreviation for blank.
All right, Ferry County, I'm expecting big things out of you.
Curlew Fire, PC. Just says PC.
Nope.
Deer Park Yammons, 3.26 light years.
That is the correct definition of how long a parsec is, but it's not what it is short for. So I do think they get a bonus for how many light years it is, but it is an abbreviation of sorts.
My computer just froze, so give it a second to, there it goes. Keysol run less than 12 parsecs. Deer Park said so they get half credit. Reclamation Fire said Keysol, Kesal, run less than 12 parsecs.
Well, the Kessel run was done in less than 12 parsecs, but what is a parsec? Yes, I know it is 3.26 light years, but what is it short for?
Plentywood, Montana said Parlac second. Reclamation said Solo. You might have to give us the answer on this one, Madeline.
Well, what was it before Solo?
The Parallax second.
Yes, a parallax arc second.
Look at that.
Very nice.
Plentywood share. I think it's Plentywood Shared Memorial Hospital in Montana. I think is where they're from. Yep. Yeah. So Plentywood, Montana, Sheridan Memorial Hospital, EMS. I think they deserve something. I think we should send them something.
Oh, Steptoe's looking upset there. Did Steptoe also have parallax arc second?
What does
Nope.
Oh no, he's just Plentywood, Montana, why don't you message me why don't you private message me your address and we'll send you something special for you guys. So that is Plentywood, Montana. Private message me your mailing address. Something special.
John, your mic keeps fading out.
Yeah, who knows what's wrong with it. Can you hear me now?
Yeah, we usually hear you at the beginning of the sentence and then it fades.
All right, hang on one second. All right, so hopefully you can hear me better now. Plentywood, Montana. Message me your address and we will send you something for getting the bonus question correct. So, is that all you have?
I do have one other just general question for y'all folks, which is in the future, I do have 2 other lectures and I'm just interested in knowing what would be useful for you guys to hear at some point in the future. And I got a lecture on intracranial hemorrhages and I got a lecture on stroke mimics. And go ahead and just, type in the group chat what things you might be interested in hearing in the future. And I'd also be interested in hearing if you thought that this lecture was too high level, too low level, or targeted just right. So if you would throw those sorts of things in the chat and just let me know so that for a future talk, I know what you're interested in, and I know whether or not this was targeted appropriately. You can also say stuff like too boring or just about right.
I guess we'll see if anybody says anything.
All right. Other than that, thanks for being here, and I'm out.
Perfect. And then the other thing is the next episode. I'm just pulling it up here, so I don't know which one it is. Next episode is going to be January 14th. And it's going to be with Travis Potter. He hasn't given me a title yet, but I will tell you it will be geared towards some post-traumatic stress / EMS mental health. So it should be a really good presentation. Travis used to be a paramedic. So he's got some really good information. He's also going to be co-presenting with possibly a chaplain. We'll talk a little about that. So it should be awesome. Thanks for joining tonight. You guys all be safe, and we will see you guys in January of the next year. Have a good night, guys.